Hello everyone, I'm Dr Gasha Othman, and this is a case presentation about a full mouth rehabilitation and bite raise case that the whole process took 1 year, and I have photographic documentation of exactly 1 year follow-up. So this is the before and after. When the patient first came in, he was actually quite well. He had no systemic diseases, was not taking any medication, quite fit for his age, 6 years of age. No TMJ clicking or no TMJ disorder whatsoever. And he had no dental pain either. When he first came in, he already had some implants done. He had 5 implants done already, and the prosthetic and the bite raise was done afterwards. And so what immediately took my attention was the over-erupted posteriors. That's later going to cause, it's going to make the process a lot more difficult and complicated. But luckily, he's very happy with the result, and now he has achieved what he came in for. So this is a retracted image, close-up image of before and after. As you can see, the occlusion is completely collapsed, where the teeth have undergone severe attrition. And this implant here has been placed with a tissue former, but it's actually in function. It's in occlusion. The occlusion is the vertical dimension is so reduced that some of these teeth need to undergo root canal treatment. And as you can see here, the first molar is so over-erupted. I was very concerned of how I was going to restore these implants with prosthetics. The final result is also not very perfect. I mean, there are some black triangles here and there, but it was a huge transformation, and it shifted his lifestyle. So this is the lower arch. This was root canal treated, this tooth, and it had a PFM crown. I didn't do a retreatment. It seemed fine. This tooth was vital. Here we did a bridge. All of these teeth were vital, and surprisingly, they were not sensitive whatsoever. If you see this tissue irritation here, this is where the palatal cusp of the upper first molar rests, causing the patient great amount of discomfort. So the antagonist tooth was in occlusion or contacting the mucosa of the ridge. And then this is the upper arch. These teeth were both vital. Here you can see some teeth have been root canal treated, and it's been worn down so much that the restorations over the root canal filling have been lost, and you can actually see the gutta-percha underneath it. So what was any of the teeth that needed retreatment, I did under rubber dam isolation, and then I put up all of the teeth that were root canal treated. I placed fiber posts, and they were built up. And then it was time to finally raise the bite. So in order to do so, I took impressions, and then the lab did a digital wax up where they increased the bite they separated the jaws by 3 millimeters. 3 millimeters can make a huge difference, but yet it's still on the safe side. And so on these 2 models, I took indexes with PVS impression material, and in the indexes I placed self-polymerizing bisacrylic for temporary restoration and placed it in the patient's mouth. Remember, I still haven't prepped the teeth yet. So this is what the result looks like. Now, a mock-up is not very aesthetic or hygienic, but here it did the job because it was quite comfortable for the patient, and I wanted to test something to see how he would respond. And because the didn't have, it's a quite soft material, and it can be worn down easily. And the cusps were not very well defined, so he had the freedom of moving his mandible, so it was like a long centric. Therefore, I didn't have many reports from him of breaking or chipping of the mock-ups. But whenever he did, he came back. I removed the old mock-up, irrigated the tissue underneath, and placed a new one. While he was wearing the mock-up, he was on chlorhexidine mouthwash. And then he spent on and off in these mock-ups for about 2 months. So after these 2 months, he had no pain or clicking or spasm whatsoever. He responded very well, actually. So that's when, after the 2 months, we started with the preps. So I prepped all of the teeth. Some of them, as you can remember, are root canal treated and have build-ups. This is the over-erupted maxillary first molar. And as you can see, there is there's the shadow of the pulp right here. This is because I over-reduced in the occlusal surface, which I would naturally have to do because I needed space for this crown and for the antagonist teeth to be restored as well. And then I took impressions of the lower and upper arches with single-step PVS addition silicone material. The centric, I needed a more precise record. So what I did, I made temporary crowns with the old index, and I let him occlude on one side, leaving the other side open, and filling this side with bioregistration material. And we recorded the maxillary position with a phasebow and transferred the record to the articulator. And then it was time for temporization again. So now we put him in temporaries or PMMA milled temporaries. Now these were much more accurate, and they would sit exactly on the finish lines. So they were much more hygienic. And the anatomy was very well defined. So the cusps were well defined. So the mandible would get locked in the maximum intercuspation. He wouldn't have freedom to move his mandible to find a comfortable position. So this led to breaking and chipping of the restoration many, many times. The first time he broke it in less than 28 hours. Now this was the true test in order to see if he could adapt to a new occlusion or not. So he was in these for about, I believe, another month. So I started making permanent restorations when he stopped breaking them. Just on the topic of temporary restorations, I'd like to point out that the difference between a milled or even printed restoration or temporary restoration and a mock-up, the one that you put with an index. This is an image of the teeth after the mock-up has been removed after 1 week. This is an image of a milled, this is the image of the teeth, after the milled restorations have been removed after 2 weeks. So you see how the difference between them. The mock-up is very unhygienic. And this is the final result, and this is images of exactly 1 year post-op after everything had finished. This central incisor was not initially implanted. Instead, it was supposed to be a root canal and a build-up in a crown. But there were some problems, and we decided to extract it and do an implant instead. Now he's very happy. It has been an amazing journey, and his occlusion restored. Just look at that view. His occlusion is restored. He's very happy, and everything seems quite stable now. And that's all. And thank you.